Thank you, Dr. Kanchan. At the outset, we would like to thank the organizers for inviting us and congratulations on this excellent scientific feast. Myself and Dr. Sambit will be talking on this topic of pathogenesis and evaluation of diabetic food.
Yeah. So, a good morning, everyone. And at the outset, I must thank Team WE for giving this opportunity. So, as Dr. Sahana has told, it's a duologue, and we'll be discussing on pathogenesis and evaluation of diabetic food.
Yes, so when we say food, it's considered as a masterpiece of engineering and a work of art. We know it's a very complex structure when it comes to its anatomy, the nerve distribution, and the vascular supply. Hence, anytime we talk about the food problems, the underlying pathophysiology is also very complex, and so also its management. And when it comes to diabetes, we call food as a mirror of diabetes care, because if we have a patient with long-standing diabetes, we're just looking at the foot, we can have a reflection on a lot of things. We can talk about an uncontrolled diabetes causing chorioarthropathy and joint deformities, peripheral neuropathies, peripheral vascular disease can tell us about the atherosclerotic process which is happening not only in the foot but also probably in the heart as well. And then it also reflects the self-care of that person and to some extent the socioeconomic status.
Yeah, so what we have thought of is that we'll discuss two very common case scenarios of diabetes, and then we'll proceed towards the proper presentation. So this is a case one. She's a 58-year-old female housewife, type 2 diabetes for last 7 years. She has got all the complication like nephropathy of stage 4 CKD with albuminuria. Retinopathy was there with non-proliferative diabetic retinopathy with CSME. Current admission was only for poor glycemic control and UTI. She has never told anything about the foot ulcer, and when our resident actually went and examined the patient, this was the foot. And if you see the foot, there were actually 3 ulcers, and 2 on the metatarsal head of first and second metatarsal head, and another in the plantar aspect of the great toe, and all were with punched out over the pressure points, and they were having a large amount of callus. So they were all neuropathic foot ulcer. Just to highlight the fact that patient may not present anything with a foot ulcer like this, you have to check the foot, and then only you can know that there is something there in the foot.
The second case is a case which is, this is a condition which is often missed both by the patient and the doctor, and we only see the chronic complication of this. So this is a 55-year-old gentleman who presented with, he's a known diabetic for 15 years. This particular patient had redness and swelling which he had noticed and had consulted locally, was treated with antibiotics, but there was no relief of symptoms. They had done a DVT screening which was negative. So what is the diagnosis? Now this diagnosis, I'll come in the end of this session and let's discuss about it later. Now here, generally diabetic foot is a very less often discussed topic, although it's very, very important. And as our organizers here have done a wonderful job by having a whole session on diabetic foot, which we feel is very, very important. So Dr. Sambit, can you tell us why is this diabetic foot management so important, even for clinicians? It's not just the surgeon's job. Of course, when there's ulcer management, we would need their help, but then it is the clinicians who need to first address the foot. Can you tell us why it's so important?
Yeah, absolutely. So diabetic foot is a very important complication, and it's one of the most dreaded complications in diabetes. 15% of diabetic patients develop foot ulcer during their lifetime, and 85% non-traumatic lower limb extremity amputation are preceded by some kind of foot ulcer in diabetes. Need for major amputation in 5 to 10 times higher in diabetic patients compared to those who are without diabetes. And if you see the mortality data, the 5-year mortality data, you can see that we have put the mortality data of prostate cancer, breast cancer, Hodgkin's lymphoma, even the pancreatic cancer and the lung cancer. The person who had once developed an ischemic diabetic foot ulcer or maybe a neuropathic diabetic foot ulcer, the chances of mortality in the next 5 years is more or even comparable to other malignancies. It is slightly lesser than the lung cancer, pancreatic cancer, but it is far more than Hodgkin's lymphoma, breast cancer or the prostate cancer. So that is the importance of discussing a diabetic foot here. So there are two thumb rules actually. One is the foot ulcer is the rule of 15, where 15% of patients with diabetes develop foot ulcer in the lifetime, so which I had already discussed. 15% of the foot ulcer will have some kind of osteomyelitis, and 15% of the foot ulcer will develop amputation. Another rule is rule of 50, and that is more dismal actually. This is the tragic rule of 50 about the amputation in diabetes, and 50% of amputations is usually transfemoral and transtibial, and that actually leads to lot of morbidity to the patient. They will lose one limb completely with lot of problems in later part of life. 50% of the patient will require a second amputation within less than 5 years of duration, and 50% of the patients will die in less than 5 years. So the mortality is also high, the risk of further amputation is high, and most of the time it's a very complicated surgery or very highly morbid surgeries. So comprehensive foot care programs reduce amputation by almost like 45 to 85%. So, Dr. Sahana, can you tell now about the risk factors and pathogenesis of diabetic foot ulcers?
Yeah, like I said in the beginning, when we say foot itself, it's a complex structure, and also the pathophysiology of a diabetic foot ulcer is very, very complex. You have multiple risk factors, but the important factors, of course, the first one is the loss of the protective sensation, which makes them prone for these ulcers and repetitive trauma. Then you have vascular insufficiency or peripheral vascular disease, deformity of the foot in a long-standing diabetes is a very, very important risk factors. And then sometimes, if there's a previous history of ulcer and amputation, we would treat that at that point of time. But then if you're not follow up and not careful on following up these patients, they might end up with second amputations, ulcers or amputations, which is very high in these patients. And the lack of knowledge of self-care and foot care is also an important risk factor for development of ulcer. Now, if you look at the pathophysiology, now I said diabetes and its complications have a very impact on the foot. First, when you start with the neuropathy, which is the most important factor, the sensory neuropathy leads to loss of protective sensations. I mean, we say that the pain is a gift of the God. That's what was described. So when there is a loss of pain is when you get these injuries and you don't even know that there is a problem in the foot, there's an ulcer or a redness in the foot. Many of our patients don't notice it until they develop an ulcer. And once there is a motor neuropathy, they start developing the small deformities in the toes or in the arches or lost, and this makes them more prone for, again, abnormal foot loading and ulcers. And then comes the autonomic neuropathy, where there's loss of sweating, the foot becomes dry, fissures, and that is also a risk for ulcer. Now, this is again further complicated by the poor vascular perfusion secondary to the peripheral vascular disease. Then again, hyperglycemia could lead to infection and worsening of this infection, cellulitis, osteomyelitis. So it's kind of a vicious cycle there. And if appropriate care is not taken, then these patients may even end up having grave complications like amputations. So most of these patients who have come with a diabetic foot would have this pre-ulcer cutaneous pathology, which is missed by both the patients and the doctors. It could be something as simple as a persistent arrhythmia after shoe removal, callus or fissures in the foot, interdigital macerations, fungal infections, and nail pathology, which has to be addressed at that point of time. Otherwise, they might end up with ulcers. And then what is this callus story? Many times we see these patients who have hardening of skin in the foot if you really thoroughly examine these patients. And this is not bothering the patients because many, they do not have pain. And maybe if we have not examined, even we wouldn't be aware of it. But this callus, it develops because of the motor neuropathy and the abnormal pressure points which develops in the foot. Now, this is again, once there's a callosity, it's further more pressure distribution in that area. There's an hematoma which breaks down and then leads to an ulcer. So these calluses are the most important, an alerting sign. Now, depending on deformity in the foot the patients have, you can have different types of ulcer wherever there is a high pressure. Like if there is a collapse of the mid-foot, like in a rocker bottom or a short course, you would have a mid-foot ulcer. If there is a high arch foot, then you would have in the anterior, the forefoot and the hindfoot ulcers. And commonly you see this finger deformities in the diabetic patients. So they would develop ulcers at the tips of the toes or at the flexion contractures. So these pressure points are one which we need to identify and then give them appropriate offloading in the times of footwear modifications. The simplest thing we can do is a footwear modification so that you reduce these pressure points. Only then we can prevent ulcers in these patients. Then comes this fissure story. Like I said, in autonomic neuropathy, this leads to absence of sweating and excessive fissure. Now, this is not only important cosmetically or it's bothering the patient, but this can be a risk factor because these deep fissures can harbor infection and can lead to ulcers. So now we saw the different pathophysiologies which could cause. Would there be different types of ulcers depending on this pathophysiology?
Yeah, so we have different types of classification about the foot ulcer, but the most important is clinical. So there are almost 3 types of diabetic foot ulcer, or if we simply classify that is, one is neuropathic foot ulcer, another is ischemic foot ulcer, and the third is neuroischemic foot ulcer. So what's a neuropathic ulcer, which is the most common variety of ulcer that we encounter in day-to-day clinical practice, is basically the person is having severe neuropathy. So mostly the ulcer develops at the weight-bearing areas of the foot, such as the metatarsal heads, the heel and over the dorsum of the clawed foot. One of the cases which I have shown in case 1 was a typical neuropathic foot ulcer. The foot would be warm and you can feel the pulsation. There won't be any absence of foot pulsation. The skin would be dry, there would be fissuring would be there, and if you do a sensory examination, definitely the sensory loss would be there. And typically the foot ulcer will look like a punched out lesion with lot of calluses. The floor may have a healthy look like a granulation tissue or pink look, but there would be lot of calluses around that. So that's a typical of neuropathic foot ulcer. Now, how does an ischemic foot ulcer look like? Ischemic foot ulcer usually happens at the areas like tips of the toes, the nail edges, or between the toes and lateral borders of the foot, where the vascular supply is precarious and it has actually decreased with the micro or macrovascular complication. Usually they are associated with some kind of discoloration of the skin or maybe a gangrene, and then you cannot actually palpate the pulses over there. The pulses may be absent and the skin would be dry, it would be pale, and there would be increase in the temperature and there would be loss of hair on the skin. So these are the types of ischemic foot ulcer or the typical ischemic foot ulcer. Now if the combination is there, we call it as neuroischemic ulcer. There would be degree of sensory loss, there would be a degree of vascular loss, and there would be minimal callus prone to necrosis. The pulses may be absent or may be very feeble. High risk for infection, and they are usually neuroischemic infected ulcers. Margin of the toes and foots are usually affected. So just to summarize, I have divided them in this tabular form, like neuropathic and ischemic. We know neuropathic happens at the pressure points, whereas ischemic in the tip of the toes or between the toes. Pain is usually absent in neuropathic, but claudication or rest pain may be there in the ischemic. Deformities are more common in neuropathic, they are not there in ischemic. The prognosis of neuropathic foot ulcer are good actually. If you are debriding and doing a offloading, the prognosis is good. Ischemic, the prognosis may not be good unless you actually do some revascularization procedures. The pulses are usually present in neuropathic, absent in ischemic. The temperature of the foot is warm in neuropathic, whereas it's cold in ischemic foot ulcers. So with that broad classification of diabetic foot ulcer, we'll go how clinically we'll evaluate a diabetic foot.
Yeah. So in clinical evaluation, again, a thorough history taking on the risk factors is very, very important, followed by some of the simple things we can do in the OPD, which we're going to talk about. Would you like to talk about what are the points in the history you would like to know in a patient with the diabetic foot ulcer?
So we all know our Hutchison days that once we start an evaluation, we do a general examination, then the physical examination, inspection, palpation, percussion and auscultation. We go exactly in the same manner in diabetic foot ulcer also. But for general examination, for all other cases we do from head to toe, here we have to do from toe to head. So foot examination is very, very important. So I'll just highlight on the history what are the things one need to ask if the person is having foot ulcer or any other risk factor for foot ulcer. So neuropathic symptoms are very important. So we ask for positive symptoms, negative symptoms, or that of the autonomic neuropathy symptoms. So what are the positive neuropathic symptoms? It's like burning sensation, tingling sensation, pinprick sensation, or electric shock like sensation. Negative neuropathic symptoms are numbness. Autonomic neuropathy, we have full range of autonomic neuropathy like dry skin, or there is gastroparesis or other autonomic postural drops and all we can ask to the patient. Vascular symptoms, we can ask about the claudication pain or the rest pain. General care of the foot and the barefoot walking practices need to be inquired, and foot care practices we must ask to the patient. Occupation, diet, smoking, alcohol, we ask in all the patients, but here it carries more importance. Past history of ulceration of the foot, because I have told the recurrence of ulceration is very fast with diabetic foot ulcer. Previous amputation or revascularization procedure has to be known. So with that, I'll ask Dr. Sahana how you do a physical
So the history taking becomes very important to understand why they had ulcer, because like I said, they're more prone for further ulceration. So you could address that risk factor. That's the reason history taking becomes very, very important. In clinical assessment also, again, we need to look at the risk factors. Of course, you would address the current ulcer or whatever problem he has, but again, we need to make sure that that doesn't repeat. So a thorough assessment would be required. So first you start with an inspection of the foot where you look at the overall structure of the foot. Now this is again not only for a patient who's come with a foot ulcer, but any diabetic patient, an annual foot examination is recommended. So what do you do in the overall anatomical assessment or an inspection? You look at the shape of the foot and look for any deformities. If you actually go back and see many of your old patients who are long-standing diabetes, you would see a lot of them have this toe abnormalities, which is called as hammer toe, mallet toe, or claw toes, depending on where they have the flexions. Now these, like I said, are abnormal pressure points. They will have pressure points at the base of the metatarsal and also at the tips and then also at the flexion. Now, so then you can also have this prominent metatarsal ulcers. Hallux valgus also, I'm sure you would have seen in many of these patients. And then in advanced cases of Charcot's, you would again have a collapse of an arch at a rocker bottom foot, which are again abnormal pressure points. Now those who have muscle wasting, the motor neuropathy, intrinsic muscle wasting, you would have this guttering in between these tendons, and that is a sign telling you they have motor weakness. Now at this point of time, the patient doesn't have an ulcer or any problem, but what happens is that many of us patients use the slippers, and then these patients have motor weakness. So what they do is they cannot hold the slippers, and also they have sensory loss, so they cannot feel if they're holding the slippers or no. So they actually put a lot of pressure and they use these tendons to hold the fissures, and that's why this flexion deformity increases and also the pressure increases. So they're not holding it like this, they're actually holding it like this. Okay, so that is why what we do advise is that we advise them to give, of course, a microcellular rubber footwear, and you give them a back strap, because then you're not depending on your toes. When you have a back strap, then your toe is completely relaxed, and when you have a proper pressure distributions, your pressure points are reduced. It's not eliminated, but at least it's reduced, and the further complications are prevented. And then you look at, of course, the skin changes. Some of the obvious like redness, ulcer, you would easily pick up. But then we need to look at some of the autonomic signs, autonomic neuropathy signs. Look, your skin will become shiny, there's absence of hair, the nails are brittle. These are early signs of autonomic neuropathy. As such, doing an autonomic nervous function testing, we know is very complicated, but these are simple signs. Some things which again we must be very cautious is the nail changes. Many patients have this onychomycosis, which is again an important risk factor. Abnormally grown nails, then toe trimming. Now again, patients, some patients are over careful and they may trim it more, and that itself again could lead to ulcers. And then corns and callosities. Like I said, they are very important precutaneous pathologies which patient will not be aware of. So once you identify this, we need to point out to the patient and tell them that, look, this is an area which might ulcer and you need to take care of it, use this footwear. Women especially, they would not go out much, they're in the home. Even if you give a footwear, they use it only when they go outside. So I always tell them to buy 2 footwears, one inside the house and one outside the house, because your purpose is to offload. Then when it comes to infections, some of the obvious like cellulitis and fasciitis, of course, would come to our notice. What we would miss is this web space infections. Here again, it's a little florid, but many would just have a mild macerations, which might be the foci. Then of course, an ingrowing toenail would lead to not always, but could lead to paronychia and infections. Then of course, when you have an ulcer, I will not go into detail, but the classical, when we learned in our, I think, the surgical manuals of how you grade an ulcer, you look at the shape, you look at the depth and all. But important is when it comes to diabetic foot is the location, whether it's a forefoot, midfoot or a hind foot, because our offloading would depend on that. The depth of the ulcer again is important to know the extensions. Then you would look at what is the vascular involvement of the infections. The different gradings, I'm not going into the detail, you have different gradings mainly to kind of reflect the extent of involvement. You have this Wagner's classification of diabetic foot ulcer, which talks about the depth, the involvement of the extent of involvement of the foot and the gangrene. Then you have this University of Texas classification, which talks about depth plus presence or absence of infection and presence and absence of ischemia. And then you have this Sinbad classification. In addition to these factors, they also comment on where is the ulcer, forefoot, midfoot or hindfoot, and the depth of the ulcer. And then again in the examinations, when it comes to palpations, skin temperature is important, very important for Charcot's foot, because some of that may be in the early stage of an acute, that may be the only sign in an acute Charcot's where you could notice this difference in temperature. You have this infrared thermometers which can easily pick up these signs, and then an increase of more than 2 degrees Celsius compared to the other foot is indicative of an active process going on. Peripheral pulses are very, very good examinations which can, if they're nice and bounding, you have a pulse, you have kind of ruled out a peripheral, significant peripheral, not completely, but you would ruled out a significant peripheral vascular disease. Some ulcers you might have to do a probe test to know the extent. And most importantly, the last but not the least, the footwear assessment. Look at what is the type of footwear the patient is using. This is very important. It takes just 2 seconds, just bend and see what he's doing. I always do that. So somebody has a deformity and they're using some inappropriate footwear. They're using pointed shoes. Now these are the things they should avoid, and we can give them a prescription for footwear. Sometimes they're not ready to use a microcellular rubber footwear, but at least tell them what not to use. So footwear inspection also becomes very, very important. So Dr. Sambit, we spoke about how neuropathy is so important, and to doing a complete neurological assessment would be difficult. What are the simple OPD evaluation we can do in our patients?
Correct. So after the inspection and palpation, we do two more important things. One is neuropathy evaluation and vascular evaluation. So I'll be talking about neuropathy assessment, but we have to be very simple and very fast. So these are the 5 simple clinical tests that you can do in your OPD. One is the monofilament test, the second is the pinprick sensation, the tuning fork test, and the ankle reflex. And if you have access to biothesiometry, that's good, but it's not mandatory. So these are the first 4 tests you can do very easily in your clinical practice. So monofilament test, how it should be done? It's with a nylon monofilament. It's a 5.07 size, and basically if you touch on the site of the skin or on the plantar aspect of the foot, if it just buckles with the pressure, that gives the 10 gram pressure to that point. So we call it as 10G monofilament test. It tests sense of touch, large nerve fiber function, and there are almost like 5 points where you should touch the nylon semi-Winston nylon monofilament. That is one on the 3 on the first, third, and fourth metatarsal heads, one on the plantar aspect of the great toe, and one on the calcaneum. Though the test varies, and some people tell it has to be done in 10 points, but these 5 points are at least very important. Another test is that if you do not have even access to the monofilament, you can do a simple squeeze test. So that is simple touching the fit, and what you touch is first, third, and fifth toe on both the sides. So that comes out to be 6 toes. You have to be very brief, just touch for 1 or 2 seconds and then take it out. If the person is not able to perceive at least 2 places that touch, it is abnormal. So there is a study where they have, by Raman et al., where they have shown that with more than 2 of the 6 insensate areas of signify at risk fit, and the specificity is quite high, around 90%. Vibration perception, vibration you need to carry a 128 Hz tuning fork, and the right place to put that vibration, or the first point is that the tuning fork has to be applied on the bony part of the dorsal side of the distal phalanx, where we usually miss. We usually do that on the metatarsophalangeal joints, but ideally it should be done on the dorsal aspect of the distal phalanx. And once out of 2 things it is negative, you can proceed proximally, maybe to the medial malleolus or to the tibial tuberosity, like that, and you can tell that the vibration is getting lost from this point onwards. And this is the ankle reflex. No need to go into that. Ideally we should check for ankle reflex also to test neuropathy. Biothesiometer is most of the time available in most of the hospitals, but it measures the vibration perception threshold, basically a more advanced version of the tuning fork test. A handheld probe is applied to fix 6 sites on the plantar foot surfaces. The volts at which the patient starts to perceive the vibration is to be noted. Anything more than 15 volts is abnormal. Between 15 to 25 volts, it's moderate vibration impairment. More than 25, it is severe vibration impairment. So the comparison of the various tests has been done by one of my friend at PGI, and he has tried to find out the different tests, their sensitivity and specificity. And if you see the sensitivity, I think monofilament has got the highest sensitivity, and specificity wise probably the vibration tuning fork is more. But nevertheless, each of these are very important, and these are the 4 tests at least you can do in your clinical OPD. So as I have told, we need to do a neuropathy evaluation, and then we need to do a vascular evaluation. So for vascular evaluation, Dr. Sahana would be speaking first.
The simplest thing we can do is to palpate the distal pulses, and another simple test we can do is an ankle brachial index, which you can do using a simple handheld Doppler, which can pick up this. Now you have this grading, I'll not go into the detail, you have this different grading of interpretations, and you can see normal was, and then you have grading from mild to severe obstructions. Now we said about so many things in foot assessment. You might be wondering, I don't have patients time to even talk to my patient, how will I do all this? Now it is so true for all of us. So what you can do is you can train your nurses who are there in OPD, or if you have diabetes counselors, you can train this, have a format, and they will actually do the work wonderfully. If you have residents, then definitely you can make use of, just have a format and tell them that these tests have to be done. Once you start doing it, the time taken is very less, and you prevent a lot of foot complications. Then you can also have this toe pressure and brachial index and the transcutaneous pressure of. And you also have this transcutaneous pressure of oxygen tensions, which you can use to kind of predict the wound healing. It's a sensor applied which measures the arterial oxygen tension, reflecting the local arterial perfusion, mostly for predicting the ulcer healing. So if it's more than 60, we say it's normal. Up to 40 is acceptable. Anything less than 20 would suggest a poor prognosis and the need of the surgical interventions. Of course, you wouldn't depend only on one test. Then you would further go ahead and do further evaluations of the arterial Doppler or an angiogram if required. So what are the now we talk about clinical assessment. What are some of the important investigations you would ask for these patients who come with foot ulcers?
Yeah. So the clinical evaluation is very, very important, starting from history to the vascular evaluation. And then we do certain specific investigations. So obviously the metabolic control is very important to assess, like glycemic status, the hemogram about the TLC and all, urea, creatinine, electrolytes and LFT are part of the panel where you need to see whether infection is there or anything else is there. X-ray foot is very, very important. In the next 2 slides, I will tell how X-ray has to be done. Biophysiometry we have discussed. Doppler study we have also discussed. If there is an ulcer, do a pus culture also, and the pulse culture should not be like a swab test from the pus. It is during the debridement from the deep tissue you take out the sample and do a culture. But what I want to highlight most is X-ray. As a physician or an endocrinologist, definitely we must order a X-ray of the foot, and that has to be AP and lateral. What we see in the X-ray is, we see the, just the previous one. So we see the integrity of each of the bones, the joint spaces in the tarsal bones. Sometimes you can see a vascular calcification over there in the plain X-ray. Here what I am showing is that in the proximal phalanx, the head is not visible actually. And if there is an ulcer, and this probably denotes a case of osteomyelitis, because the head of the proximal phalanx is almost gone in the great toe. The first diagram on the left side again shows osteomyelitis. You can show almost a destruction of the first metatarsal head. The second slide is very important. Here almost all the tarsal bones, the structure is distorted. They look like a bag of bones, and the midfoot is completely gone. So that's the case of Charcot. The third, if you carefully see, then you can see an ulcer, and there is destruction of the bones also. But what is more important to see is the gas inside the soft tissue. So that shows there is some gas formation and severe infection in that patient. So we have almost discussed about the clinical evaluation, we have discussed about the pathogenesis, we have discussed about the investigation. Now I will just ask Dr. Sahana about that second case, which seemed to be quite interesting. So your point.
So we had a patient with diabetic foot who came with redness and swelling, not improved with antibiotics, DVT negative. So when you have such a when you have redness and swelling, you have a whole lot of differential diagnosis. But what was highlighting is that this patient had redness and swelling, but then no pain, and also did not have any systemic symptoms, and investigations again did not have any inflammatory markers. Okay, of course you have to rule out a DVT and other things, but then this is pointing towards an acute Charcot's foot. Now sometimes imaging may be helpful, but in acute Charcot's sometimes X-rays are completely normal, so it has to be a clinical diagnosis. Why we put up this case is, I feel this is a diagnosis which is very, very oftenly missed. It's only when they go into a chronic stage and they come with a full-fledged rocker bottom foot is when we see, or they come with an ulcer is when they see. But it's important to recognize this acute Charcot's, and it is we clinicians only who can pick up these and give them appropriate care. So sometimes imaging may be helpful. So this is it's a degenerative neuroarthropathy which affects the multiple bones in the foot. It's a potentially life-threatening condition which has to be addressed. Now there are different stages. Because of the lack of time, I wouldn't go through all the detail, but then it progresses through a stage of inflammation, fragmentation, coalescence, and finally it enters your chronic stage where it kind of gets fibrous and these bones are totally deformed. Now there's nothing much we can do at this point of time, and then if you do not recognize even at that time, you can have very high pressure points and they will come up with ulcerations. So it's very, very important to diagnose these in a acute stage. Now this is a chronic phase where it's kind of already kind of fibrous, but you can see that the arch is totally collapsed, and you can see it has become a rocker bottom. So imagine when the patient is standing, the whole weight of the body is transmitted to that particular deformity, and it's taking all of our weight. Obviously it's prone for ulceration. So again, offloading at this point also is important, but most importantly recognize in the acute phase. And why it is important to recognize, now you do not have any medical therapies which have shown to completely reverse this process, although bisphosphonates and ours are advised, but only thing which really prevents this is offloading. Identify in an acute stage and offload these patients for a longer duration, sometimes 3 months, sometimes 6 months, sometimes even longer. But that will really protect the foot of the patients, prevents this collapse of the arch, and helps them to maintain this plantigrade foot. That is an important message we wanted to give with that case. So with this, I think do you want to summarize and give kind of a brief overview of the foot assessment?
So I think that was very interesting case, Dr. Sahana, because a painless unilateral swelling with maybe a redness should not be missed. Probably we are dealing with a Charcot foot. So coming to the end of our presentation, we have discussed the pathogenesis, we have discussed the history, clinical examination, the neuropathy and the vascular assessment. Then what we should do actually, how we can prevent a diabetic foot ulcer, because it may lead to further complications. So these are some of the suggested steps that we can take. Like, we have to classify the risk category of the patient. The risk category 0 is there is no loss of sensation, protective sensation, no PAD or peripheral lateral disease, and no deformity. In that, we ask the patient about the footwear and annually we follow it up. For risk category 1, where loss of protective sensation is there, we ask the patient to do proper foot care and maybe some prophylactic surgery if needed. Early 3 to 6 months follow-up is needed. Stage 2 risk category, if there is peripheral lateral disease, which is more problematic, consider prescriptive accommodative footwear and consider vascular consultation. Every 2 to 3 months we can call. If the patient is having history of ulcer or amputation as in category 3, we have to call the patient every 1 to 2 months and assess the patient and do some preventive steps. So with that, we'll end.
Yeah, I think the more and more focus would be on prevention of foot complications. So that's the highlight we wanted to give. So foot care can make a difference between saving a foot or losing a foot and life, and always put the foot first in our patient's examination. So in our diabetic patients, so we do not miss these complications. Thank you.
Thank you. Thank you.